Hi friends, is it possible to perform phaco in a small pupil in an eye that also has floppy iris? Well, to start with, I should say that had I known this patient was on tamsulosin, I definitely would not have attempted phaco without using some form of pupil dilating device. But the patient who had undergone a bypass surgery for a triple vessel block 6 months ago and all attention was diverted towards this, a history of use of alpha adrenergic antagonist was not elicited and therefore it was totally missed. And this is the reason why I took up this case, which had a grade 2 nuclear sclerotic cataract of 4 mm pupil, without knowing that there could be a possibility of a floppy iris existing. So this is the case as you see it, and unfortunately my OT assistant started the recording of this case somewhere after I started performing the capsular rhexis, and this is where we are taking it. I perform a pupil hugging capsular rhexis and I successfully complete it. Please keep a careful watch on the way the iris is behaving. During hydro dissection, there are some vermiform movements of the iris and a tendency of the iris to prolapse. Not all patients who are on alpha adrenergic antagonists like tamsulosin will have floppy iris, we know that, and not all types of floppy iris are the same. It could be mild, moderate or severe. Let's see how this case panned out. This was just a grade 2 nuclear sclerotic cataract and I am going to do phacoemulsification. The power is 30% and I'm using a vacuum of 300 millimeters of mercury. But even as I make my first job, I find that the iris tissue and the pupil behaving very oddly. There is twitching of the iris surface and there is a tendency of iris to prolapse both through the side port and the main incision, giving the pupil a somewhat cat's eye appearance or an ovalized appearance. It is at this point that I think that the patient could have a floppy iris, and then I was regretting my decision for not having put in a pupil dilating device, because that will completely negate the difficulty of having to handle a floppy iris. But having started the case, I'm continuing. I'm making two little modifications. One is I reduced the power from 30% to 25% and the vacuum from 300 to 250. I direct the bevel of the phaco probe downwards so that the bevel is facing away from the iris and the pupillary edge, and only after the piece has come and attached itself to the phaco handpiece, I give power in a controlled manner. As the piece starts to disappear, I immediately reduce the power because both the power and vacuum are in the linear mode. The second strategy that I use is to take the piece and then set it astride the pupil. So the piece is there between my phaco tip and the pupillary edge. This kind of a setup would actually enable me to remove the piece without attracting the iris or the pupillary margin directly into the phaco tip. A lowered bottle height, a lowered vacuum, lowered power, and also employing two strategies whereby I am able to linearly control the power and the vacuum. Following this strategy, I was able to get out the entire nucleus, or so I thought, but always beware that when you have a small pupil, there are infinite chances that small pieces may be left behind either of the epinucleus or of nuclear remnants itself. Using a wipe pusher, I retract the iris and I'm now doing cortical aspiration, and then I find small pieces just coming out and getting removed. Now this alerts me to the possibility that there could be pieces hidden somewhere. Therefore, I launch into a pretty careful search to locate any small pieces that could be there. Everything looks good, and I think I'm almost come to the end of the surgery when suddenly I see that there is something hulking behind the iris superiorly. Seems to be a pretty large piece of nucleus. I fill the chamber with viscoelastic and then I tease this piece out with a Sinskey hook. It's not a nucleus fragment, but it happens to be a large piece of epinucleus, and this is the reason why I tried to remove it with the coaxial IA itself. The 0.1 mm aspiration port of the coaxial IA can aspirate thick epinucleus if you are able to crush it against this opening using very high vacuum. Vacuum used is 500 and the epinucleus is crushed against the aspiration port and removed. Make a careful search for any retained fragments, retained cortex, and make sure that everything is cleaned up, because leaving behind fragments can lead to chronic hydrocyclitis, sometimes unexplained postoperative glaucoma. So that's it. So I examined it more or less thoroughly and everything seems to be nice and clear. So this is a hydrophilic acrylic intraocular lens that's implanted with a little amount of nudging into the capsular bag. And after that, just to make sure that there are no more retained fragments, I perform what I call the pivot maneuver. This pivot maneuver is able to sweep off pieces from within the capsular bag and bring it out into the pupillary area. This does not release any fragments and therefore the capsular bag is free and smooth and empty. And that brings us to the end of the case. So a case of floppy iris, definitely handled successfully by using a few strategies. Thank you for your attention.